Hi, everyone. I'm Dr. John Norian with HRC Fertility. I'm a double board certified reproductive endocrinologist. Oh my gosh, what a mouthful. Anyways, today I'm here with two awesome people, Caroline Moon and Patricia Rubino. Both are high-level embryologists in our laboratory, embryology laboratory in our Pasadena facility. So I'm going to let them introduce themselves. But Caroline, maybe you could tell us a little bit about yourself, followed by Patricia.
Okay, so hi, I'm Caroline. I went to UC Berkeley. I double majored in molecular and cell biology and public health. I've been in the IVF field for 15 years now, almost 2 here at HRC Pasadena, and I'm really excited to be a part of the team here.
Patricia, why don't you tell us a little bit about your background?
Yes, I'm Patricia, I'm Italian. I've been an embryologist for 20 years now, 15 of them in Italy. I graduated in Italy in biology, and I have 2 master's degrees, one in general biology and one in biotechnology of reproductions. I've been working for HRC Fertility Pasadena for 5 years now, and I love my job. I mean, I love it because it's the job that let me apply the science to make the people happy. So I love science, so I can use science to make people happy and realize their dreams.
You know, I love that. Our team, we're so blessed to have an awesome team of really on it, clinicians, on it, scientists. I love the little onesie that you see from babies. My first babysitter was an embryologist. So it's pretty amazing what you guys do. And you do much more than babysitting. Oh my gosh. So guys, today let's talk eggs, let's talk sperm, let's talk embryos. We're developing a little series where we're trying to talk about the science related to what happens in the laboratory. So part 1, we're going to start with sperm and start with fertilization. So Caroline, maybe we'll start with you. Step 1, when you receive the eggs or the oocytes from the nurse in our surgery center, what do you do? How do you handle the eggs? Talk me through it.
So we receive the follicular fluid from the nurses, and we search through all that fluid under a microscope to find all the eggs and gather them into a petri dish. If we're planning to do one type of insemination, ICSI, we'll clean the eggs of the surrounding cells so that we can assess their maturity. And we'll put that dish of eggs into the incubator until it's ready for insemination.
Very cool. So once you get the eggs, it depends on which method of fertilization you use, how you clean the eggs. So maybe, Patricia, if you don't mind, talk to me. How do you fertilize the eggs? Like, how do human eggs get fertilized? Wow.
We have 2 kinds of fertilization we can use. It depends from the quality of the sperm, the previous indication, if the patient has had a previous fertilization failure, the age of the patient. There are indications that can drive us to which kind of fertilization method we can use. So we have the co-incubation, where we just add the sperm to the eggs, and we let the sperm do all the job. So the sperm look for the eggs and fertilize. If the sperm is poor from some reason, so we don't have enough sperm, they don't move well, then we move toward the ICSI. So it's the embryologist that manually insert the sperm into the egg and make sure that the sperm can make it inside the egg. So there are, summarizing, 2 types of fertilizations, the co-incubation and the ICSI. And it depends from the sperm quality mainly.
I love it. I love it. Yeah, 2 different methods. One is very Darwinian, you put the egg around a droplet of sperm and you let the best sperm win, or the co-incubation method. And then the other is ICSI. So Caroline, let's talk a little bit more about the sperm. So how do you prepare the sperm for fertilization? Like, what do you do in the lab once our male patients prepare the sperm? How do they give the specimen, let's say. When you receive it in the sterile specimen cup, how do you prepare it for fertilization?
Okay, so we actually layer it over a gradient and we centrifuge it so that all the mobile sperm end up at the bottom of the tube. And that's the specimen that we use for insemination.
So a gradient. So a gradient, if I'm understanding, and please correct me if I'm wrong, but a gradient has like different concentrations of like sugar, right? Or what is it? What gradient do we use? And how do you get the strongest sperm? Is it because the best sperm, they can swim through the thickest sugar?
Correct. So I believe the concentration of our gradient is 80%, and they need to swim through this, kind of viscous solution to make it to the bottom. So we know that the sperm that pellet at the bottom are the strongest swimming sperm.
I love it. In the office, I tell people it's, the most handsome sperm wins. But I'm not sure that's really what happens. But, what can we do? So, all right, Patricia, I'm not sure about this one. And this one, I'm sort of, throwing you off guard a little bit. But is there a way that we can assess sperm quality, like underneath the microscope? Like, how, when you do ICSI, that's the method where you select a single sperm and you inseminate it directly into the egg. How can you assess sperm quality? Are there any things you look for as a scientist?
Yes. On top of everything, what I like to choose is the sperm that move the best. So even if I'm doing the ICSI, I always look for the sperm who's going straight and is going faster, because it's the one that would most probably in nature get to the egg. But there are methods, several methods in the science that you can use to pick the best sperm. A few years ago, there was very in fashion the high magnification, so we can look at the sperm at 3,600 magnification fields. So we were looking at the vacuoles and the nucleus. It's a very time-consuming technique that is not in use anymore. But these are the methods where you can pick the sperm while you're doing the ICSI. Of course, this is a fertility lab, so we receive the sperm that has been analyzed already from the andrology lab. So all what we look is the motility and the concentration. But there are many ways you can assess the quality of the sperm, like the fragmentation of the DNA, the morphology. This is something that we cannot do in the lab, because all these methods mean that the sperm, once it's being analyzed, needs to be thrown away. We need live sperm, so we do just a minimum assessment and then we do the ICSI.
It's great you brought that up. Sometimes I order tests like that. Believe it or not, guys, men can play a role in miscarriage if the DNA of the sperm is really fragmented. I mean, sort of crazy. Everyone blames it on the female, but sometimes the sperm can also play a role. So there are other tests. Even a live dead sperm assay is something that's done.
Yes.
Okay, Caroline, question. So we talked about ICSI. We do it when guys have really low swimming sperm, low motility, low shape sperm. But when else is ICSI indicated? Or have you ever seen ICSI done for non-male reasons, I guess?
Well, ICSI can be used if a couple has tried conventional IVF, like what we mentioned before, and maybe fertilization. So maybe there's a factor that we didn't see that ICSI can correct for. Or there are other labs where if we're going to be doing genetic testing of the embryos, they prefer to do ICSI so that there aren't any leftover sperm kind of hanging onto the egg or the shell of the embryo. What else, Patricia?
Yeah, usually you should never do the ICSI unless there is not a male factor, but it's true that the ICSI has a higher fertilization rate. So you do ICSI every time you don't want to risk no fertilization. So if you had a previous fertilization failure with a common co-incubation, if the patients are at an advanced maternal age, so the eggs that you retrieve are very precious, so you want to absolutely maximize the fertilization, then you can push the ICSI. So every time you don't want to you don't want to risk that you have a fertilization failure. So that's why the ICSI sometimes is pushed more than it should. But every time you want the fertilization failure, you do actually an ICSI.
Yeah. So ICSI, sometimes, just to summarize, we use it if you're doing maybe other advanced techniques like screening the embryos. That is a little bit controversial, I understand, but that's definitely something
techniques, if you have methods that use PCR, then maybe you want to do a ICSI to avoid the leftovers of the sperm. But yes, you can do a co-incubation if you're doing a pre-implantation genetic testing, a common one, you can totally use co-incubation.
Got it. Got it. So there are other reasons to do ICSI besides just male factor. All right. So guys, I want to change it up a little bit. Let's switch and let's talk eggs a little bit. So, so just quickly, just reintroducing ourselves. I'm Dr. John Norian. I've got two wonderful embryologists with me. Caroline Moon, she's an alumni of UC Berkeley like myself. And we've got Patricia Rubino, a really dedicated, awesome researcher from University of Milan and Padua, and has done crazy amounts of embryologic work over her career. So we're so fortunate. They're both based in HRC Fertility Pasadena, where we do our retrievals and transfers and things. So awesome. Guys, thanks again for being here. But let's talk eggs. So egg quality. All right, this is a hard one, guys. Me as a fertility doctor here in the clinic, here in the office, I order tests beforehand. I do like an AMH level, a follicle count, maybe an FSH. We do all these little things to get an idea from a blood test about a woman's egg quality. We also know definitively that female age very much plays a role in egg quality. But I've got both of you here. Talk to me. Are there any things that you see underneath the microscope when you're handling the eggs that give you a sense of a woman's egg quality? So whoever wants to go first, please do. One thing, Caroline, just if you want to make sure that your microphone's up, just so we can hear you, that'd be great. Okay. Maybe Patricia, why don't you start if that's okay?
Yes, we can assess the quality at two levels. We can just assess the egg quality with all the cells that surround the egg. Which are called granulosa, that gives an idea of the maturity of the eggs, and this is with all these accessorized cells that the egg is around, is how the eggs gets co-incubated. We can clean the egg, like Caroline was saying a few minutes ago, when we do the ICSI, and then at this point we can assess the fine morphology of the egg under the microscope. So we can assess, first of all, the maturity, which is determined from the mitotic stage, meiotic stage the egg is. So we see a polar body, we determine if the egg is mature. But we can see other morphological features like vacuoles, endoplasmic reticulum, all morphological features that are correlated or not with the quality of the egg and the fertilization potential of the egg. And we can tell the clinicians if for example, the stimulation this time was appropriate, if they have to change something about the stimulation, and we can give more information about the quality to the clinician.
Got it. So by looking under the microscope, you can see like how clear the egg is, or if there's a lot of debris, the endoplasmic reticulum or vacuoles, which are these little bags of like debris, and that sort of gives you an idea. But the egg maturity, like you mentioned, is really another big factor. So Caroline Moon, wonderful. She and I had worked together on the East Coast, but then she left and went to a high-level clinic in Atlanta. And at that time in America, a lot of major egg freezing research was coming out of Atlanta. And she was so fortunate to be there and learn from some of the pioneers about how to freeze and thaw eggs. And I was wondering, sort of, Caroline, if you could just sort of talk through in a layman's term about like, how do you freeze and thaw eggs? What is that? Or talk to me.
Yeah, so egg freezing, we had a really big breakthrough in 2005. Dr. Kuwayama published his paper, his protocol on how to vitrify oocytes, eggs. And vitrification is a really neat technique. It's an ultra rapid, fast freezing technique. And what's great about that is that the freezing process happens so fast that ice crystals do not form. And this is a big change from before. The protocol before was a slow freezing technique. And ice crystals are dangerous because they're really sharp and they could damage cellular structures. So maybe when you do a thaw, your eggs or embryos don't survive. And with the slow freezing technique, egg survival was maybe about 60-65%. And with vitrification, we see survival rates of up to 80-90%. So we see a huge improvement in survival rate and a significant increase in pregnancy and live birth rate.
Yeah, that was a game changer. Wow. I don't mean to date myself, but I remember when that was happening in like 05 to 09 and seeing that thaw survival rate going from something that was really small to 90, 85, 90+% in certain hands. I remember I like to think in my hands, I've seen you guys in our lab in Pasadena, our thaw survival rate, I think in the right person is even higher than that. But I'm really proud of the work that our team does. In vitrification, that's that snap freezing, like you just said, that ultra rapid freezing prevented the ice crystals from forming and damaging the egg. So what solution are these eggs in? Like, what's a cryoprotectant? Is that really like antifreeze like we have in our cars? Like when we go skiing?
Yeah, it's actually pretty similar to the antifreeze in our cars. They actually have the same main component. It's called ethylene glycol. And in our vitrification media, we also have the cryoprotectant DMSO, dimethyl sulfoxide, and a sugar called trehalose. So all these components contribute to preventing the formation of ice crystals, much like the antifreeze in our cars prevents, the fluids from freezing over.
Got it. So for either of you, how long do you think the eggs last, and what temperature are they frozen in?
Sure. So as long as the eggs are kept at the proper conditions in liquid nitrogen, they should be pretty much good indefinitely. I think there's some papers showing that embryos still result in pregnancy after being frozen for 30+ years. And the temperature of liquid nitrogen is negative 196 degrees Celsius, so very, very cold.
That's awesome. It's amazing that human gametes, eggs, sperms, and embryos can be frozen at such a cold temperature. But that's what preserves them, right? Because they're suspended in time or suspended in a cryopreservative. So, all right, awesome. That was fun. That was really fun learning about eggs and egg freezing, egg quality. That was awesome. Thanks, guys. So now what I'd like to do is let's switch gears. Let's talk embryos. All right. So embryos are these structures where we have both the egg and sperm together and they fertilize. So they go from having 23 chromosomes coming together and having 46 chromosomes, which is a human. That's what the humans have. So let's switch it up. So just again, briefly, I'm Dr. John Norian. I've got Patricia Rubino, wonderful embryologist, and Caroline Moon, high-level senior embryologist in our laboratories. Patricia, how does an embryo develop? So the last we spoke, we were talking about bringing the egg and sperm together, and they're a one-cell fertilized egg or a zygote. So then talk me through it. How do you get from one cell all the way to that full blastocyst? And how many cells does a blastocyst have?
Yeah, more than 100. So we go from one cell where the nucleus of the oocytes and the nucleus of the sperm are separated and then join. They finally form one nucleus with 46 chromosomes, like you were saying. And after that, there are symmetric divisions that happens in the eggs. So symmetric divisions and a pair number of cells. So from 2, 4, 8, 16, until in day 4, after 4 days, these cells starts to compact one each other. So the border between the cells are not very defined anymore. They becomes a morula, so kind of a sphere again. After that, some liquid starts infiltrating between all the cells, and we form a cavity which is called the blastocyst. And finally, we are at the blastocyst stage where you can find two lines of cells. So until the blastocyst stage, all the cells are the same. They're gonna do all the same. They are totipotents. You say they have all the same function. After the embryo become blastocyst, you can distinguish two lines of cells: the trophectoderm, which is gonna end up in the accessorize of the embryo, like the placenta, and the inner cell mass, which is going to give the embryo the real fetus. At this point, we don't have the we can culture the embryos anymore. So once the embryo becomes blastocyst, it either needs to be frozen or implanted in the uterus. So until the blastocyst stage, we can grow the embryo in the lab. After that, we need to freeze it, or the embryo needs to do something. We need to put the embryo somewhere.
That's amazing. So correct me if I'm wrong. You're saying up to day 4 or so, up to the morulus age, any cell that's part of the embryo can sort of become anything.
Yes.
And then once you get to that day 5, day 6 blastocyst, where you have two parts, you have two groups of cells, one being the baby portion and one being the placenta portion, then they're starting to declare, I'm on team blue, I'm on team red. Is that right?
Yes, exactly.
Yeah. All right. So now we've got this blastocyst, and I know there's a technique out there that's called like how we can screen the embryos, or even before I get to screening the embryos, maybe yourself or Caroline, you guys could talk to me about, do you guys grade the embryos? And if so, like what are some things you're looking at when you're determining which embryo is most beautiful or most handsome? So as embryologists, tell me, a little bit more of what you're looking at.
So as Patricia said, we grow our embryos out to the blastocyst stage. So it usually reaches that stage by day 5, 6, 7. And at that point, there are two components: the inner cell mass that becomes the fetus, and the trophectoderm, which becomes the placenta. So we give each of those components a grade, A, B, or C, A being the best, C being the worst. So we're looking for if it has a lot of cells, if the ICM is compacted, and we're also looking at the expansion of the blastocyst cavity. So there's this fluid-filled cavity, and depending on how big it is, we also give that a grade.
Got it. Okay, so how many cells, the shape of the cells, and sort of how big the embryo is that right?
Correct.
And then you get like a score for the baby portion, and you get a score for the placenta portion?
Correct.
Yeah. So that's based on one of the pioneers in our field. I think David Gardner was a embryologist who really sort of, along with many other people, sort of pushed the envelope and had a little more of like a standardized criterion. And our laboratory, of course, follows that, and we've used that system to study things. And how important do you think grading is? Do you think, and what do you think, like when you're selecting an embryo, do you want to base it more on grading of the embryos, or would you want to know the chromosome number of the embryos as far as which ones are going to implant?
It's important. It's important, especially, of course, in the literature, you can find what you need to prioritize to choose the embryo. So both are important. Of course, you want to know the content of the embryo, so if it is chromosomally normal. But you want to also know how quick and fast and well this embryo is growing. So if I have a slow embryo, which doesn't reach the expanded blastocyst stage on day 5, but doesn't on day 6, most probably, this doesn't tell us that doesn't tell us good about the embryo. So I'm going to choose the embryo who's developing better, who's developing faster, and of course, the chromosomal content. No, we think the grading of the embryo properly is very important. So it goes in the same level of the chromosomal content.
Got it. Okay. So I even got ahead of myself a little bit right there, because I was talking about chromosome. So can one of you talk about the technique that goes into determining if an embryo is chromosomally normal and what that's called?
It's called pre-implantation genetic testing. There are two types of pre-implantation genetic testing. One is general. It is called the pre-implantation genetic testing for aneuploidies, and it applies to everybody. We'll actually find the anomalies, the abnormalities the embryo in the general population can accumulate, because the embryo is dividing day after day. So while divides, these cells can accumulate mistakes in dividing all the chromosome. It's a very complicated job from the embryo. It needs to replicate the chromosome, it needs to divide the chromosome in each cells in the same exact number, so that all the cells are euploid. While it's doing this, can accumulate mistakes, and then can create an aneuploid embryo. So the pre-implantation genetic testing for aneuploidy will find the embryos that maybe were accumulating mistakes while they were dividing, so we can exclude them from the transfer. So this kind of pre-implantation genetic testing is going to show, for example, if you have a Down syndrome, the embryos of Down syndrome, or Turner syndrome, of their major problems with the chromosome. Of course, the more advanced at this stage of the women, the more all the molecular mechanisms inside the oocytes don't work well. So when the embryo is dividing its chromosome in the cells, they might accumulate more mistakes than in a young woman. So it's very, we advise that especially advanced maternal age women to do the pre-implantation genetic testing for aneuploidy. But there is also another pre-implantation genetic testing that is for monogenetic disorders. And in this case, we will find out if there is a disease that is recurrent in that family. We can screen the embryos and exclude them from the transfer if they carry this genetic disease. So one is for the general population, and one's from the population that actually know they have a disease recurrent in their family.
Yeah, that's wonderful. It's such a good explanation. So one is screening the chromosome number, like Down syndrome, Turner syndrome, and then another one can even screen like a little point mutation on the human code, like cystic fibrosis or sickle cell. So two main different techniques. How many cells do you get when you biopsy the placenta portion of the embryo? And Caroline, do you think it damages the embryo when you do that? Talk me through it.
So when we biopsy a portion of the trophectoderm, we usually take about 5 to 10 cells. But at this point, the embryo is a few hundred cells. So we're taking a small portion of the embryo that's going to become the placenta, not the fetus. And studies have shown that as long as the biopsy technique is done properly, you don't see much damage to the embryo. It can still implant as well as embryos that have not undergone this procedure.
Yeah, especially if it's a chromosomally normal embryo, the thaw survival rate is so high that that I think the benefit of screening the embryo definitely outweighs any theoretical risk that's there. All right, so guys, that was great. Thank you so much for talking to me a little bit more about embryos. I have a better understanding about it, or I hope the people listening do for sure. What I want to do now is just sort of wrap up and just talk a little bit about technical stuff. And I'd also like to learn a little bit more like what it's like to be in the laboratory. Like, what are your guys' personalities like when you're in the laboratory? So myself, Dr. Norian with HRC Fertility, we have 2 wonderful embryologists with us, Caroline Moon and Patricia Rubino. So talk to me, when you're in the lab, are you guys listening to music? Is it really loud? What do you guys typically wear? I know you guys don't have hair coverings on right now, but talk to me. What's it like in the lab?
We don't play a lot of music. There's usually a lot going on. There's a lot of, communication between embryologists, us and the doctors, us and the nurses. So we don't have a lot of music playing in the background. It is pretty tight quarters. So we do, it's nice that we all get along really well. because again, we do have to have really clear communication and cooperation between us.
Yeah, I whenever I walk in the lab, it's like you guys have your game face on. I mean, very pleasant, very smiley, but you're working, you're concentrating. That's what I see as an outsider. And to be fair, I try not to go into the lab, and when I do, I always put head coverings on. I have booties. I walk on the sticky surface. It's our clean room. What, Patricia, how do we do some like quality assurance where we can keep the lab really high level and up to date as far as making sure?
We have the micro quality insurance. So every day we test the temperature of all our instruments. We test the pH of our media, which is the most important part for our culture system. We want to be sure that for each lot of media that we receive every time the media, the gas we use in the incubator is keeping the right pH of the media. This is the micro quality control that we do every day. And we keep our environment clean. So we wear gears like hat, masks, our scrubs. And once every year, we measure also the particles in our air system. So the technician comes and measure how many particles we have, the dimension of the particles, and it tells us if our air is clear. It's in a good. We have a clear room. For doing that, we have filters. The filtered air that is coming. A positive pressure inside the lab will push all the possibly pollution, the possibly particulate outside the lab, and this is how we keep our lab clean. This is the measure, let's say the measure maintenance, the measure quality control that we do once a year. So we get a certification about our air quality.
Yeah, whenever we pass the eggs off, we pass it through the window, and that's under positive pressure. So the door opens pretty quickly and closes pretty rapidly. So, yeah. So we talked about your activities inside the laboratory. You're like even trying to get to know you a little bit more. Like, are you guys like, do you enjoy getting outdoors? Are you guys enjoy reading? What are some activities that you guys enjoy when you're outside the lab?
I know Patricia and I both love to travel, which unfortunately we are not able to do right now. I know we're both kind of going stir crazy, but definitely looking forward to getting over all this COVID stuff so we can start exploring again. I really enjoy scuba diving. That's one of my big passions. How about you, Patricia?
So I have tons of interest. I love animals. I have tons of animals. I have a dog, a cat, a guinea pig, mice. I love plants. So my house is called the jungle. So I have plants everywhere. I love outdoors. So I hike every weekend with my dog, and I go on the beach. And I love traveling. So I would just travel all the time. So I've been here for 5 years, and I've been in 15 states of the United States already. So every time I have time, I just go in the car and travel. I get a plane and go somewhere, and always very short, with a very short preparation, just go. These are my.
You're probably like an embryologist. You're probably very detailed, very focused, very precision. Get in, get out, explore.
Yes, and then I'm very European, so I love art. So I go for city. I want to see museums and theaters and stuff. So yeah.
Yeah, that's awesome. That's awesome. Maybe I was really proud of our lab. We presented some really exciting research, Patricia, that you had led. I know that Caroline, you had done a number of papers with egg freezing back in the day. Any new things in the pipeline or new things that you're excited about for either of you in our field that you can comment on?
You want to start, Caroline?
Oh, why don't you go? I think you're more the research person.
Yeah, I'm very excited about the PGT field now. I think there is something interesting in the future. They are starting to screen the embryos for the potential that they can carry any kind of disease like breast cancer, colon cancer, So what we are looking at in the future is for classifying the embryos from the most healthy to the less healthy. So we have another way of classifying the embryos other than just morphology or aneuploidy. And what we are working really, this is the genetic part, right? The platforms that they're using. For us as embryologists, what we are very working really hard on is trying to find a way, a non-invasive way to assess the genetic content of the embryo. So we would like not to biopsy cells anymore, but we're trying to assess the genetic constitution of the embryo from the spent media, so which DNA this embryo is throwing outside. We are we're getting creative to find ways not to damage the embryo, but still get information about the genetic status of the embryo.
I love that. It's such an exciting field and a line of research that's going on right now. Non-invasive screening of embryos, not just prenatal testing. So, guys, I think we should probably leave it there. What a fun way to spend an afternoon. Just sort of talking eggs, talking sperm, talking embryos, and learning about some of the magic that happens in the lab. So. Again, I'm Dr. John Norian with HRC Fertility. My guests today were Caroline Moon and Patricia Rubino, high-level senior embryologists, really passionate about creating amazing embryos that really bring all of our work and all of our success to existence. So, guys, thanks so much for joining me. And have a great rest of your day. So thank you.